Okay. So I tried to reorganize some of the questions just a little bit before I started the review, just in case you do see some questions that aren't in the exact order of how she posted them, just because I wanted to put like if there was a couple questions on shock, making sure they were together if they were about the same thing. So that way it would be easier for us when we're going through all the questions. So I just want to let you know, and just in case you see it, a little messed up. But okay, so the first question that we have is to assess and identify nursing interventions for a client experiencing respiratory alkalosis. So the first thing that I want to talk about is always knowing the lab values, right? So for respiratory alkalosis, right, that means the pH is going to be high and the CO2 is going to be low. So does anybody know what the normal pH level should be and what the normal PaCO2 level should be?
Normal pH is between 7.35 to 7.45, and for PaCO2, it's 35 to 45.
Exactly. So, respiratory, remember the pH is going to be inverse relationship with CO2. So, in respiratory alkalosis, we have a high pH, so greater than 7.45, and a PaCO2 of less than 35. They are hyperventilating, so they are breathing very quickly. Now, something that I've seen in the textbook and things is that when it comes to respiratory alkalosis, we need to correct the hyperventilation. So, what is causing that? And common causes include pain, anxiety, fever. Okay, so those are really common causes of respiratory alkalosis. So, anxiety is one of the most common causes, right? If you're anxious, you're going to breathe faster. So, usually they'll say breathe through a paper bag. That's one intervention if it's related to anxiety. And if that doesn't work, we can give them anti-anxiety medications or sedatives if it's that bad. But for this question, she did emphasize using a paper bag. If it were caused by pain or fever, we'll treat the pain with, analgesics or different comfort measures. And if it's a fever, we'll treat the fever with like acetaminophen or something like that. Any questions on that?
No.
Okay. So the next question is to assess clinical manifestations of a client with dehydration and provide patient teaching. So when I was looking through like the notes and stuff and I was looking through a bundle that I have, I noticed that it was saying that sometimes fluid volume deficit can also be called dehydration. It just depends on the circumstance. So I'm gonna go over like some of the manifestations of fluid volume deficit, which are very similar to dehydration because they're used interchangeably. But Dr. Remy mentioned for the specific question that for dehydration, they'll usually have confusion. And dehydration is caused from not drinking enough water, whereas fluid volume deficit is not getting enough fluids and electrolytes. Okay, so when we're thinking about dehydration, we're talking about it's a problem with water and them not getting enough water, whereas fluid volume deficit is a little different. She said for this, we want to encourage them to increase their oral intake. However, when it comes to the situation, obviously, if they're very confused, we may not give them oral fluids, but she did mention we want to work with the patient if, they're really not confused and they're not at risk for aspiration to give them those oral fluids. Um, Other sorts of manifestations include confusion. I like to separate it by system. So for neuro, we're talking about confusion and we're talking about fatigue. For respiratory, we'll typically see tachypnea, right, which is that increased respiratory rate. Um, when we have cardiac manifestations for dehydration, we're talking about a rapid and thready pulse, tachycardia, orthostatic hypotension, um, capillary refill being delayed, things like that, okay? Also, the skin is going to be affected, right? If they don't have enough water or they don't have enough fluids, right? They're going to be cool and clammy and they'll have dry mucous membranes and have weight loss. Labs will also increase. I'll get into that later because that's going to go into the next question. And late signs of like dehydration and going into fluid volume deficit would include oliguria, a flattened JV, and also the central venous pressure will decrease. And normal central venous pressure is between 8 and 12. So overall for this question, like I said, fluid volume deficit manifestations mimic pretty much dehydration manifestations. Just the difference is that dehydration is due to a problem of not getting enough water, whereas fluid volume deficit is not getting enough fluids. Any questions on that?
No.
Okay. So like I said, if we can, because it's dehydration, we want to encourage them to get drinks orally, right? If the question doesn't say anything about them being super confused and they don't know where they are, we'll give it orally. If they are really confused and they don't know where they are, we'll have to give them fluids a different route. Okay, the next question is to indicate lab values that are indicative of dehydration, right? So, as we said, fluid volume deficit, dehydration, the signs and symptoms mimic each other. So, dehydration will expect all labs to increase. So, hematocrit, which is typically between 42 and 52% for males and 35 to 47% for females. And that's just because, females menstruate. Um, every month. So we will not have as much hematocrit or as much hemoglobin as a male would. Hemoglobin will be between 12 to 16 for females and 14 to 18 for males. Remember, it's going to be higher for males for both hemoglobin and hematocrit, and it's going to be lower for females. We also expect the serum sodium. I'm not talking about urine sodium. I'm talking about sodium levels. So 135 to 145, sodium is going to be greater than 145. BUN, this is the lab value I got from the textbook. And when I was doing practice questions from the textbook, it said 8 to 20. Her notes say 10 to 20, but I've never really seen them give like a lab value too close. And I don't think she'd give a question where the lab values would be like a BUN of 8, a BUN at 8.1, a BUN. Like, I don't think she'll do that. I think she'll put one value and it's either correct or incorrect. So just like think about that when you're looking at the questions, right? So BUN is going to increase as well as creatinine. Creatinine is 0.6 to 1.2 according to our textbook. And I did notice that Dr. Amit emphasized while going over dehydration is that the bun to creatinine ratio should be between 10 to 1 and 20 to 1. So anything greater than 20 to 1 would be indicative of dehydration. Keep that in mind. Urine osmolarity will also increase. Her value said 250 to 900, but when I was doing research, most of the time the osmolarity, I haven't seen it be other than around 250 to 300. So our textbook said 270 to 300 is normal. So that's the range that I'm going to be using when I'm referencing my lab values, as well as urine sodium is between 75 and 200. That value was pretty accurate on her sheet because it varies by place. It could be like 45 to 210, but roughly that value is normal. Urine specific gravity also will increase, and it's between somewhere of 1.005 or 1.030. It's okay if you also use hers of 1.003 or 1.030 because if you're looking at a question, if you see it on the lower spectrum, like 1.005, 1.004, 1.003, we know that's more of a decreased value, and that's not what we're looking for. We're looking for something of 1.030 or greater when we're talking about dehydration. So those are the labs at values. If you know that in dehydration, they're going to increase, we know the opposite is going to happen for fluid volume excess. That's why if you know the values, all you need to know is which ones increase and decrease in which scenarios. So that brings me to, I'm not going to go over the lab values that indicate dehydration again, because we already talked about them. But is there any questions?
No.
Okay, so we talked about the values. Like I said, when we're talking about urine specific gravity, you could reference either one because if you see it on that lower side, you just know, okay, when I'm talking about dehydration, that's not going to be correct. I expect it to be on that higher side of 1.030 or higher. If I'm talking about fluid volume excess, I expect it to be 1.05 or lower. Okay, so the next question is to identify signs and symptoms of hypocalcemia. Okay, so calcium levels, I do see them variate like in different textbooks, but I've never seen them give a calcium level so close to the actual lab values. They usually make it 7 or 8 on the lower spectrum and 11 and 12 on the higher spectrum. So I wouldn't get too tedious on the exact decimals. Just know around 8.6 to 10 point something is around that normal range of calcium, but the textbook says 8.6 to 10.2, and sometimes they use 8.8 to 10.4. But I would just know, a reference. Like I said, I've never personally seen questions where they're so meticulous to the number. But so hypocalcemia, we're thinking about, right, let's just use this value for reference of 8.6 or lower. Typically, like I said, I see it around the sevens when they talk about it, or as low as 8. Um, so we know that calcium is controlled by the parathyroid hormone. So that is really important. So when we have hypoparathyroidism, they could even say in the question that the patient has hypoparathyroidism, which would make me think, okay, they are at risk for hypocalcemia. So you have to think about different ways that they could ask questions. But I'm pretty sure this question will be just identifying the signs and symptoms of hypocalcemia. So I like this little mnemonic that I kind of added to it, but it was originally cats go numb. So the C stands for convulsions or like shaking, arrhythmias for the A, tetany, which also means spasms for the T, and S for seizures. And then the go numb. So they have numbness or parasynesthesia. I want you just to know these different types of words that can be used because she can mention parasynesthesia and you could be like, I don't know what that is. It's also numbness. And I added the like to the ending because she also mentioned dyspnea as a sign that you can see when you have hypocalcemia, as well as hyperactive DTRs or hyperactive reflexes or hyperreflexia, different ways of saying the same thing. So that's why my little mnemonic for remembering calcium levels is cats go numb, duh, because I could put each letter to a symptom. Now, does anybody know the two tests that would be positive that would let me know, hey, this person has hypocalcemia?
The Shep stack and the trousseau sign.
Yes, I know they're kind of hard to say. That's why I'm happy. I didn't say that one. I have no idea, so I'm not going to say that. But yes, those two signs that you see right here are going to be positive. Now, I think it's Chavesky. I don't know. I don't think I'm saying it right, but it's when you have a tap on the cheek and it spasms. That's a sign of hypocalcemia. And Trousseau's sign, I'm saying it like that, is when you press the blood pressure cuff onto the arm, like on a really, really high, pressure like 200 and then their arm like spasms. Those would be indicative of hypocalcemia. And something that helps is when you have a low calcium level, they're more excitatory, which makes sense for the arrhythmias, for the spasms, for the seizures, whereas hypercalcemia is more sedating. So we talked about the signs and symptoms and think about it, right? If they have seizures, right, we need to make sure they're on seizure precautions as well as being aware of they're having low calcium levels. So we need to monitor calcium levels and replenish calcium levels through like IV calcium gluconate, um, oral calcium supplements, things like that. As well as some other management that I'd like to point out is just hypocalcemia always relates to hyperphosphatemia. So we also would want to educate them to decrease their phosphorus intake. And common things that phosphorus is in is like beans, chocolate, and milk. So I just wanted to put that out there. But remember, this is signs and symptoms mainly for the question, but I just wanted to let you know in case you see it. Okay, so the next question is to assess a client on respiratory acidosis and provide lab values to monitor. So we already said respiratory, we're talking about an inverse relationship between pH and PaCO2. So the pH is going to be less than 7.35 and it's going to be greater than 45 for the PaCO2. They are hypoventilating, okay? So we typically see this in patients who have chronic respiratory conditions like COPD, emphysema, or even if they overdose on opioids, okay? But this is the lab value. So you're looking for a low pH and a high CO2. The next question is identify clinical manifestations of respiratory acidosis. We said this is hypoventilation, right? Whereas respiratory alkalosis was hyperventilation. So Dr. Remy said for this specific question to watch out for hypoventilation because there's hypercapnia and that could eventually lead to hypoxemia. So know that when we're talking about respiratory acidosis, we're talking about hypoventilation. Other things that the textbook said is that they could have like mental status changes, they could feel fullness in the head, but I would know that the main one is that they could have hypoventilation. Okay, that's the main thing when we're talking about respiratory acidosis. Does anybody have anything else to add? Okay. All right. So yeah, remember, respiratory alkalosis is hyperventilation and respiratory acidosis is hypoventilation, and keep those in mind. Okay. So now we have to identify clinical manifestations of fluid volume excess, or also called hypervolemia. So I want you to always know if you can't remember all of these things, if you know what the signs and symptoms are for fluid volume deficit, it's basically the opposite for fluid volume excess. So for fluid volume excess, we expect for respiratory tachypnea, crackles, cough, right? Because they have fluid buildup. Their cardiac status will be bounding pulses with tachycardia with a high blood pressure, not a low blood pressure like we saw in fluid volume deficit or in dehydrated patients, right? These patients will also have a distended jugular vein. For fluid volume excess, we expect them to gain weight as well as having edema. That's not something we'll see when we have a patient with fluid volume deficit. Compared to our fluid volume deficit patients, right, those lab values that we spoke about would increase, but in fluid volume excess, they decrease. So hematocrit decreases, hemoglobin decreases, BUN to creatinine decreases, which means the BUN to creatinine ratio will be less than 10 to 1. Okay, that's the things that we're looking for. That urine osmolarity is going to decrease, the urine sodium is going to decrease, and that urine specific gravity is also going to decrease, right? Because these patients don't have a problem with going to the bathroom. So their urine is going to be very diluted. It's going to be in that less than 1.005 range, right? That's why also all the other urine values decrease. Whereas in fluid volume deficit, right? They're not peeing at all if they are peeing. And whatever is going to come out is going to be super concentrated. And that's why that urine specific gravity is going to be greater than 1.030. Also, central venous pressure will increase, right? Imagine if there's fluid going on in your body, things are going to increase. The volume of fluid is going to increase compared to decreasing because there is no really circulating fluid in someone who has fluid volume deficit. Now, this mainly talked about the manifestations, but just be aware, right? Daily weight is going to be our best way to know if this person is gaining weight. I know it's going to tell us a lot because we want them to restrict fluid and sodium intake, right? And we want to watch for edema, and also monitor responses to diuretics, right? We typically expect someone who has fluid volume excess in order to remove those fluids to get diuretics. So that could put them at risk for fluid volume deficit as well as electrolyte imbalances. So those are some different things to point out. Anything anybody wants to add? Okay, so the next question is nursing management for inappropriate antidiuretic hormone or SIADH, right? So that means syndrome of inappropriate antidiuretic hormone. So we spoke about this before. Dr. Remy specifically mentioned for this question, you want to restrict fluids because they have fluid retention. Now, just as a reminder, right? Syndrome of inappropriate antidiuretic hormone is when the body is making too much ADH or too much antidiuretic hormone. That means antidiuresis, so they're not peeing, okay? So that they're going to have a decreased urine output. So they have a decreased urine output, and in return, they're going to build up with water in the body. Now, not in the tissue space or the interstitial space, but in the intravascular space, which means water is going to build up in the blood vessels. Okay, that's why we don't see with these patients typically peripheral edema, because edema is caused when fluid goes into the interstitial space. This is when fluid is going into the vascular space. So we have to watch out for cerebral edema and jugular vein distension with these patients because, right, where did the vessels go? They go right towards the brain, towards the heart. So those are things that we could see expanding, right, and or swelling. They'll have weight gain, right, because they're retaining water, right? They'll have oliguria. Like I said, they have too much antidiuretic hormone, so they're not peeing. They'll have nausea and vomiting, and, right, they'll have hyponatremia. Why? Because the water is building up in the intravascular space, which is going to dilute the sodium that's in the blood cells, which is going to lead to hyponatremia. Okay, so low sodium levels of less than 135. So with these patients, right, we want to monitor the serum sodium. We want to monitor for seizures because of the risk for cerebral edema, as well as hyponatremia can cause seizures, right? As well as restricting fluid intake, right? She said anywhere between, doesn't really matter the exact ml, but restrict fluid intake between 800 to like 1,000 milliliters because, right, they're gaining weight from the fluid, or I should say properly, the water that's filling up in that intravascular space. So we don't want to continue giving them fluid, okay? And we could also give them hypertonic solutions to help increase the serum sodium. But regardless, these are the types of things that we need to watch out for. Remember, this is a person who is retaining water in the intravascular space, so we want to put them on fluid restrictions. Any questions?
No.
Okay. The last question is to identify clinical risk factors for clients on nasogastric tubes. So, nasogastric tubes, that's when we're suctioning and we have all of this drainage and everything's going on with that NG tube, right? So that could decrease fluids, decrease electrolytes. So that can put them at risk for metabolic alkalosis, as well as vomiting, medications like diuretics, or if they increase bicarbonate through, eating it somehow or just taking supplements that are high in bicarbonate, right? But metabolic alkalosis is typically caused by things that result in loss of fluid. So, like I said, vomiting, gastric suctioning, and nasogastric tube drainage, medications, and things like that. So we're looking for, remember, metabolic always means the same thing is happening, meaning the pH is high, the bicarbonate's going to be high. So the pH will be greater than 7.45 and the bicarbonate will be greater than 26. Normal bicarbonate is 22 to 26, okay? And yeah, so like I said, risk factors, think of anything that relates to fluid loss. So NG drainage, vomiting, medications like diuretics and things like that. Okay? All right. So that's it for fluid and electrolytes. We could start getting into shock if nobody has any more questions. Okay. So What are some interventions that we could do to reduce infection for a client with a central venous line? Well, the first thing that I want to point out is I went to the textbook and I found somewhere, I don't know where, but somewhere it said, what are the nursing interventions that are essential to reduce the risk of infection? So it said one, maintaining sterile technique when changing the central dressing line. That's exactly what Dr. Remy said, right? When we're changing the dressing or doing dressing changes, it's sterile. We always need to perform hand hygiene before manipulating and accessing the line ports. If this was a select all that apply, even if I didn't know about the sterility, non-sterility, I would know to pick hand hygiene if I'm going to be dealing with something. That's always something we want to pick, right? They should always have good hand hygiene. So maintaining sterility when we're doing dressing changes and performing hand hygiene before touching or manipulating those lines. When we're going to access the line, we can use clean gloves, okay? But we have to use sterile gloves when we're doing a dressing change. Also, before we put anything into that central line, we want to do hub scrub of 15 to like 30 seconds with like alcohol or chlorhexidine, something like that, so that we can reduce any sort of biofilms or anything that could be building up on that access port. Because remember, you're putting different medications, different things are going in there. If we're not cleaning it, right, it can put the patient at risk for infection, especially because this is a central line, right? So remember, sterility when doing dressing changes, always do hand hygiene before, and you could use clean gloves before accessing the line port. We want to do scrub hubs, which is 15 to 30 seconds with either alcohol, chlorhexidine. Other things said that, you can consider antiseptic containing ports, which are like the little caps that are infused with alcohol or something to put onto the port as a cover, as well as using chlorhexidine containing dressings. But I would say this is primarily what we're looking out for, right? And that's what Dr. Remy said. Sterile technique when we're doing dressing changes, clean when we're going to access the port, make sure we wash our hands, and monitor the site for infections. Does anybody have anything else to add? Okay. So now we talked about that. We talked about a central line. Now we're going to talk about the cardiac clinical manifestations for someone who's in shock. Now, this all depends on how the question is presented. And here's my mentality on this type of question. If it just were to say, which manifestations would I see in a patient in shock, and it said nothing more than that, I'd be looking for an answer that either says, because we're talking about cardiac, either increased heart rate or decreased blood pressure. If we're talking about compensatory stage of shock, we're talking about tachycardia, right? So increased heart rate, but the blood pressure and cardiac output is normal. And that's because the body is compensating for the shock. This is when the body says, okay, I see what's going on, but I'm going to maintain cardiac output. I'm going to maintain the blood pressure. Other things that are going to be going on in the body, though, is tachycardia, confusion, decreased urine output, respiratory alkalosis, as well as they'll be cool and clammy, right? But for progressive, what happens now is the mechanisms that were supposed to be keeping the body stable, to keep that blood pressure stable and that cardiac output stable, have failed. So now, if the question said they were in progressive, I would look for these symptoms, which include tachypnea, so increased respiratory rate, which is usually described as rapid and shallow respirations. Tachycardia, a decreased blood pressure, because now the blood pressure decreases, is no longer stable because the compensatory mechanisms failed. They're still going to be confused. They could even have loss of consciousness. They're still going to have a decreased urine output. Their skin is still going to be cool and clammy, but now instead of being in respiratory alkalosis, they're going to be in metabolic acidosis, and they're at risk for DIC, or disseminated I don't know the whole term for that. But DIC is basically when they have a lot of clotting that's going on in their body, and that's putting them at risk for bleeding. So we typically would see also in this patient like petechiae and ecchymosis on their skin. Okay, so like I said, it all depends on the question. If the question just said, what are clinical manifestations of a person who's in shock, and it said cardiac manifestations, I would pick increased heart rate and decreased blood pressure. Now, if it said this person's incompensatory, I would pick the symptoms that we talked about for compensatory. And if it said progressive, I would pick the symptoms that we talked about for progressive. Does anybody want to add anything? Okay, so the next question is assess a client on in the progressive stage of shock and provide clinical manifestations. Now, like I said, I reorganized these questions a little bit. So I figured if we're talking about shock and we already mentioned progressive, let's continue to talk about it. Well, we already talked about the symptoms. So it's that decreased blood pressure, the tachycardia, the confusion, the decreased urine output, right? Potential loss of consciousness, metabolic acidosis, rapid and shallow respirations, DIC, and they could also have chest pain because of the lack of perfusion. Remember, shock is caused by hypoperfusion or lack of perfusion to the tissues, to the organs. So they can also have chest pain. So now that we talked about that, we talked about what the manifestations are. Let's go a little bit more into the pathophysiology, right? So we said that in this stage of shock, compensatory mechanisms fail. And that's why where we saw in compensatory that blood pressure was normal, the cardiac output was normal, and they were in respiratory alkalosis, that fails. Now they're in BP, right? They have a low blood pressure, they have low cardiac output, and now they're in metabolic acidosis. Okay, so now they're in an acidotic state. All of their organs are suffering from this hypoperfusion, right? So as a result, they can go into loss of consciousness, further mental status changes, right? The lungs are also going to experience decreased blood flow. So that's why they're not having respiratory alkalosis anymore. Now they're having these rapid and shallow respirations. Um, there's not enough perfusion to the heart, so we're having dysrhythmias and all of these things. That's why we're having all of these functions. Everything's starting to shut down. And that mean arterial pressure, which is keeping that, that was keeping that blood pressure and cardiac output stable, which should be between 70 and 100, is now below 70. So if it's below 70, usually they refer it in the 60s or lower, that means there's poor circulating perfusion in the body. So that is the pathophysiology. So remember, in this stage, we're talking about compensatory mechanisms fail and things are getting worse. Any questions? Okay, so I'm not going to define the pathophysiology again, but just remember, we're talking about hypoperfusion, we're talking about compensatory mechanisms fail, which causes further deterioration or further exacerbation of the symptoms they're already getting, and now they're in metabolic acidosis, and their blood pressure drops, and that map falls, okay? So, I'm not gonna repeat because we already did it, and I want to make sure we get through every question with everybody's answers and all that. Okay, so the next question is provide nursing interventions for a client receiving dopamine via a central line. So what I had that Dr. Remy said was, one, we need to verify a dose with another nurse. We need to taper dopamine, and I'll explain why. Give dopamine via central line or controlled pump. There needs to be some sort of controlled mechanism with dopamine because the levels have to be tapered very diligently, and I'll talk about why. Monitoring vital signs because dopamine is a vasoconstrictor, so it's going to cause an increased heart rate and an increased blood pressure. And we also have to monitor urine output, and that's because dopamine has receptors specifically in the kidneys. So it helps reperfuse the kidneys, which is going to cause an increase in urine output, as well as This being a vasoactive drug, it's also called an inotropic drug, which means it improves the heart's contractility that can put the client at risk for arrhythmia. So we also want to have EKGs present and readily available to monitor this patient. Now, the reason I said that we have to be very careful with the levels of dopamine is because we need doses between 2 and 8 micrograms per kilogram per minute to improve contractility. Because if it goes higher than 8 micrograms, right, we're talking about more vasoconstriction, which can increase the afterload and increase the workload of the heart, which is basically just going to be really undesirable and it's not going to be good for the patient, okay? We want to get the heart going, but not too much and overwork, okay? So that's why dopamine has to be very carefully titrated and tampered with, okay? It's only between, at least the textbook says 2 to 8 micrograms per kilogram per minute. As well as things that I was saying in the textbook, right? I forget, this can be given through a potential central line. We have risk for extravasation and necrosis, and lots of adverse effects have to do with the heart, right? We said there could be arrhythmias or irregular heartbeats, shortness of breath, dizziness, right, from all that vasoconstriction, especially if it, we've raised that level a little too high, right? They can have lightheartedness, passing out, severe headaches, confusion. They can have a whole bunch of problems, okay? Sweating, tremors. So, that's why we need to be very, very careful with dopamine. Now, does anybody have anything else that they want to add?
I'm good, thank you.
Okay. So yeah, we basically talked about both. Like I said, I don't know what the I guess when she's talking about route, I'm guessing she means using the controlled pump because she mentioned that. I feel like this question would be like a select all that apply or something like that. But we already talked about what it is, right? How to give it, why it needs to be tapered so closely. And remember, if you can't remember a lot of the terms that we said, it's also a sympathomimetic drug. So it means it mimics the sympathetic nervous system. So that's the type of signs and symptoms we expect to see in a patient who's getting this. Okay. So we're good with dopamine. Okay. The next question is to provide nursing interventions for a client with septic shock. Now, just as recap, septic shock is circulatory shock that starts from an infection, usually a bacterial infection, right? And it's causing vasodilation. Usual signs and symptoms include key giveaways to know that this person's in septic shock is that they'll have an increased heart rate, decreased blood pressure, a temperature, as well as warm and flushed skin. Why? Because they're vasodilating. If the blood vessels are opening, they're not going to be cool and clammy. They're going to be warm and flushed. Also, when you have a fever, you're more warm and you're flushed than being cold, okay? So, nursing interventions, right? If we're talking about an infection, potentially bacteria, we want to give antibiotics, right? We want to give fluids, right, to help raise that blood pressure. And fluids are always needed for someone who has a fever. Always, you need to keep their hydration status very high when someone has a fever because, that is not very good. And fevers can cause a lot of dramatic effects in the body if it gets too high. So hydration status is very important. We want the Trendelenburg position. Why? Because they have a lower blood pressure. We want to raise that. They can have lactate in their blood, which is basically from anaerobic mechanisms, which means that instead of normally being in aerobic, we're now in anaerobic because of the acidotic state causing lactate to build up in our blood, which is not very good. So in order to counteract that, we can give them lactated ringers. That helps with that. We can give PPIs or famotidine for ulcerations. That's something that they can be at risk for while they're in septic shock. We want to monitor, we already talked about the importance of the vital signs because we're looking at that heart rate, that decreased blood pressure, and especially that elevated temperature of like greater than, let's just say 101, right? We want to get a CBC. Why? Because they're having an infection. So we want to watch the WBC count, right? We would also want to get a urinalysis to see, right? if there's bacteria in their urine and what kind of bacteria. So we want a urinalysis and we also want cultures, right? And lastly, we want to make sure that they have a good IV site and that IV site is free from infection because that's only going to make this septic shock worse. Is there any questions or anything anyone wants to add? Okay. But also, even if you're like, oh, how am I going to memorize all these symptoms? It's okay if you can't, right? Think about what it is. Think about it's a bacterial infection. Think about what are some things that you could do to help someone who has a fever. Think of the manifestations, right? Increased heart rate, decreased blood pressure, fever. So we want to treat those things, right? If we know it's caused by infections, we want to get tests to tell us, is it an infection and what kind of infection, right? And lastly, always rule of thumb, you could always pick monitor dynamic statuses, right? Look at daily weight, nutritional status, all of those things, right? And we talked about a bunch of other things that we could do in addition to that, right? Okay. Now, the next is to identify clinical manifestations of hypovolemic shock and provide nursing management. We talked about fluid volume deficit. Those signs and symptoms are the exact signs and symptoms that you'll see in hypovolemic shock because it's basically just fluid volume deficit at a worsened state. So we typically see hypovolemic shock due to things like hemorrhage, surgeries, and burns, right? So we talked about manifestations of fluid volume deficit. So it's the same symptoms. So we're talking about pallor, that cool and clammy skin. We're talking about tachycardia with a rapid and thready pulse, right? A decreased blood pressure. They could potentially go into cyanosis, right? They'll have a flattened JV, right? Oliguria, and they'll have a concentrated urine output, which means they're going to have a high urine specific gravity as well as a decreased pulse pressure, which is just the difference between the systolic and diastolic. So we talked about, right, different manifestations, and this is exactly what fluid volume deficit is. So if you know those signs and symptoms, you already know what hypovolemic shock signs and symptoms are, okay? Now, if it talks about in the question how to treat it and it's talking about blood pressure, right? We could put them in a modified Trendelenburg position, which I kept seeing in the textbook coming up for that. And for Dr. Remy, she specifically said we want to give fluids, isotonic fluids, like lactated ringers and isotonic solutions, right? Because we need to raise the blood pressure. The goal for hypovolemic shock is to get the circulating volume back up. So if we see an answer choice that says administer fluids, we're going to go for that, right? If the question is talking about signs and symptoms and it's talking about blood pressure, giving fluids is going to increase that as well as putting them in a modified Trendelenburg position. So if we're thinking hypovolemic shock, our goal is to fix the circulating volume. So we need to give fluid to this patient as well as correct the blood pressure, which means giving them fluids will do that, and also putting them in a modified Trendelenburg position. Is there any questions about that or anybody wants to add anything?
The modified Trellenberg is the same like the regular Trellenberg position?
I believe so. I never saw a difference, but every time on Course Point when I did questions, it even if it had Trendelenburg, the answer was always modified Trendelenburg.
Okay.
But I don't know if Dr. Remy would put either of those. Like if I just saw Trendelenburg, I would personally pick it if it were a selected that apply. But Course Point kept saying otherwise. That's why I just wanted to mention that to you, just in case, because if she goes by her textbook, that's what it kept saying. The last thing I wanted to point out is that for colloid solutions, the recommended colloid solution is albumin for hypovolemic shock. And when someone who is hemorrhaging, we give them albumin. Dextrin is contraindicated, and I don't know exactly what page it was on. The textbook said you can go to page like 308, but one of the charts said that dextrin is contraindicated in hemorrhage and shock, and that's because it increases platelet aggregations and it leads to bleeding. So we only would want to give albumin. If it said what solution or colloid solution would be contraindicated in hemorrhage, it would be dextrin. I see a hand raised.
Hi. Alicia?
Yes.
My background is a little noisy. So there is a difference the between the modified. The modified is like your body's level, and then the regular one is like your body's tilted lower than your legs. I don't know if you understand what I'm saying.
So you're saying like with modified, they're more flat still compared to Trendelenburg, they're
You're more
lower?
flat. You're more flat, and the other one your head is tilted lower down, like all the way down. So it'll be your head will be lower than your legs, and in the modified everything is level, kind of
Oh,
like that. That's what it says.
I didn't know that. I wish
Yeah.
the textbook would have said. I mean, I couldn't
So
find it.
there is a difference between both.
Oh,
Thanks,
oh,
Anna.
Okay, you're
yeah.
welcome.
Thank you for that. I had no
You're
idea.
welcome.
I just kept seeing it in the textbook, so I knew if I had to pick an answer, I'd pick modified because it kept saying that's the preferred position for someone who has hypovolemic shock. But I appreciate the clarity on that because now I actually know what I'm talking about. Um, but okay, yeah. So now we understand what modified Trendelenburg, and that's why we give it for hypovolemic. Um, and it's also just probably better because like imagine just laying this person all the way like flat or like in that like the head's lower than the feet and they're already suffering with like tachypnea and they're having trouble breathing and now we're going to put them their head all the way down, they're probably going to suffer from that even more. So that probably wouldn't be fun for that patient. So I think it makes sense that modified Trendelenburg would be the preferred position for someone who has hypovolemic shock. Um, okay. So we talked about hypovolemic, we talked about the colloids. Like I said, albumin is for hemorrhage. Dextrin is contraindicated in hemorrhage. Just know that. Like I said, there's a few different places in the textbook that say that. I don't know. I screenshotted a picture of the chart, but it said you do not give dextrin in hemorrhage and like an active hemorrhage. Okay. The last thing is to identify the benefits for a client receiving enteral feedings. And what Dr. Remy said is basically is that it's used to replenish nourishment to promote GI functions. And I also saw in the textbook that malnutrition basically impairs the patient's resistance to infections. So making sure that they're properly nourished means that they're also having a better chance to fight infections. So those are two things that I saw that could be a reason for why it's beneficial to give enteral feedings. Does anybody have anything else to add? Okay. So now we're on chapter 12, which is management of patients with oncological disorders. So, um, the first question is to provide clinical manifestations of a client with prostate cancer and the factors contributed to this diagnosis. This is where I start moving things around with questions, but it's still all the questions are there. So, when we're talking about prostate cancer, right, the first thing I want to talk about is the manifestations. Okay. So, for manifestations, think about prostate. Well, if we're thinking about male anatomy, we're thinking about a really big prostate gland starting to interfere with the bladder and the urethra, and it's causing problems with them urinating, right? The bigger it is, the more it's going to block. So they're typically going to complain, think of urinary problems or urinary complaints when someone has prostate cancer. So we're looking at, right, urinary retention, we're looking at dysuria, which also means painful urination. I wanted to point that out in case you see it. They will also have blood in the urine, which is also called hematuria. I want to point these out because she might not just put blood in urine, she could put hematuria, and you should know that's what that means. They will also have potentially oliguria and anuria, or they're not peeing at all, or oliguria, they're peeing very little. Other things that I saw is that the textbook also said that if the cancer is large enough, it can basically affect the bladder neck, and that's why we have signs of potential urinary obstruction. It could also lead to painful ejaculation. So if we're talking about males and we're talking about something blocking the bladder ability of a male, we know a risk factor or a factor that contributes is male gender, right? According to the textbook, the highest population group to have risk for prostate cancer includes African American males. They have the highest risk for prostate cancer. It said increasing age greater than 65 puts you at risk for prostate cancer. A diet high in red meats and dairy also puts you at risk for prostate cancer, as well as a family history. So, those are factors that would contribute to the diagnosis of prostate cancer. So, if we're thinking about the factors and we're thinking about all of these things, we have to look at nursing management, right? So, for nursing management, right, if the factor is a risk factor is family history, we need to gain family history, we need to get information. If a risk is right, advancing age, and we're looking at all of these risk factors, right, we're also going to need to assess, this thing affects urinary retention. It basically affects your ability to go to the bathroom. So I need a urine history, a family history. We need a nutritional history because a diet of high in red meats and dairy can also contribute to someone having prostate cancer. We also want to look at a urinalysis to detect blood in the urine or hematuria. And those tumor markers, right? Like a PSA, that prostate specific antigen. Normal is between 4 to 6, and high is 6 or greater, which puts you at a greater risk for having prostate cancer. I'm not really sure what the bladder irrigation thing is. If anybody wants to explain what that is, um, I would love that because I'm not really too sure what she was talking about when she was talking about bladder irrigations for nursing management.
I'll explain since that's something we do in the OR.
Okay.
So bladder irrigation, the surgical term for this procedure is called transurethral resection of the prostate. So what happens is a little camera that goes through the urethra all the way until the bladder. In the bladder, it is already expected to have abnormal cellular growth that is already going to be confirmed by biopsies, the tumor markers testing that they do prior to that. And it depends on what stage of prostate cancer patients have. Then they go through a surgical procedure where they remove it. So with this camera, there is an attachment where we call it a loop resectoscope. It gets attached to the camera. So then you put the camera inside until it reaches all the way to the bladder, and you're watching this like a video game on a screen. And that's when they cauterize and remove chunks and chunks of abnormal cellular growth on the bladder. So and we call them a lot of bladder chips because they do look like chips. These are a lot of abnormal cancer cells. And then what happens is eventually when this camera has been taken out, they put what we call an ELIC. That ELIC is kind of like working as irrigator pressure. So it gets pressurized, goes right through the urethral bladder. So there's like an inflow irrigator and there's an outflow. So the outflow, the whole thing, you're going to get a lot of irrigation that has a lot of bladder chips, which they will collect them for specimen to be sent out to pathology. So that's what she means by bladder irrigation. The actual surgical term is called transurethral resection of the prostate. TURP.
That's TURP, okay.
TURP. That's what it is.
Okay.
But it's a surgical procedure that involves a lot of inflow and outflow irrigation. And I guess that's the nickname they call it, bladder irrigation.
Well, I appreciate you taking time to explain that. I was very confused when she spoke about that because I heard bladder irrigation, then TURP, and I had no idea what it was.
Exactly. So it means the same thing, not an extra procedure. Because I saw too, like bladder irrigation, then TURP, but it's the same thing that Safina just said. Okay, thanks.
Is it clear for a lot of people who are on the Zoom at the moment? Like, do you understand the concept behind it? Everybody?
I think you've explained it very well. I mean, I can't speak behalf for everyone else, but I think the silence indicates yes.
Okay. All right, let's proceed.
Okay, thank you. I just wanted to ask because I'm not trying. I don't want to explain anything I don't know because I'm not. I don't want to say anything else.
If you the exam, something about the surgical procedure, just or bladder, just know it is the transurethral resection of the prostate, or TURP. That's what it is.
All right. Thank you. I'm very happy about that. So now I understand, and now we have an understanding. Plus, you'll have the video so they can go back and listen to it if they need to rehear the explanation or they want to hear it again.
No problem.
Okay, so the next question I thought would make a lot of sense to do after is identifying clinical manifestations of acute prostatitis. I'm so sorry. That word was just not coming out. And provide nursing management. So if we talked about prostate cancer as a problem with blocking urinary flow, this is also a problem with the prostate, right? So there's some sort of bacterial infection that causes inflammation of the prostate, which is going to also include fever and chills, right? Because it's an infection. Urinary changes still. So, if we're still having problems with urinary changes, they're still having at risk for oliguria, we want to, one, give them antibiotics. Why? Because it's a bacterial infection. We can give tamsulosin because tamsulosin is an alpha adrenergic agonist, which simply means it mimics the alpha system, which basically helps you go, wait. Yeah, so basically it helps you go to the bathroom. Just know tamsulosin is going to help you go to the bathroom. So when you take tamsulosin and you're taking the antibiotics, you're helping with the infection and you're helping them go to the bathroom. We also want to follow up with the provider. And why do we want to tell them that they should urinate standing up? What is the rationale behind that? Because I'm personally not too sure why they have to urinate standing up. Like, why is that better?
Maybe the gravity, I don't know.
I'm
Standing up.
thinking pressure from the bladder neck.
Maybe it helps with just like getting the stream out. I'm guessing that would make sense.
Probably.
I'm really not too sure. But just know that tamsulosin is going to help you go to the bathroom, make you pee. We're going to give them antibiotics. We want them to follow up with the provider, and we want them to urinate standing up. Okay. So the next question is to provide care for a patient with cancer. So when we're thinking about cancer, we have to think about the manifestations, right? So we know they have like myelosuppression or bone marrow suppression, right? So they need neutropenic precautions. They also are at risk for thrombocytopenia, which puts them at risk for bleeding. They'll have fatigue. They'll have weakness from anemia. They have stomitis. They'll have alopecia, which is hair loss. They'll have nausea. They'll have vomiting. They'll be in pain, and they'll have poor nutrition, which means thinking about all of these things, that's how we're going to care for our patients. So with neutropenia, we're going to put them on neutropenic precautions. With thrombocytopenia, we're going to protect them from bleeding, and we're going to also monitor for signs of bleeding. For anemia, we're going to help treat that, with different supplements and try to help with the fatigue and weakness. We want to increase their nutrition, decrease their fatigue, alleviate their pain, as well as helping improve their body image, right? Because having, let's just say, stomitis, having loss of hair, all of those things could affect your physical appearance and make you feel a certain way. So we want to help them improve body image as well as maintain tissue integrity, because like stomitis and all of these things, right? They're like little redness, little inflammatory spots in the mouth, and it's causing redness, little ulcerations, and bleeding. I see a hand raised.
Oh yeah, I had a question about the stomitis. What would be like the nursing intervention for that? And is that because they're of the thrombocytopenia or something else?
Oral hygiene, I think.
I think because the radiation like starts to promote like a little bit of skin breakdown. It could be kind of harsh on the skin and also those mucous membranes. So they start getting like ulcerations potentially. So oral care is usually something you would do. You don't want them to like brush their teeth really hard.
Soft bristles and maybe normal saline rather than mouthwash that is very irritant to the gums.
Exactly. All of those things. Things that would just basically be really gentle for the mouth, right? We don't want to like overstimulate the mouth with things because they have ulcerations. I don't know if you've ever had a canker sore. You can kind of think of something like that. Like imagine having a bunch of those in your mouth and you're, eating really hot or salty, spicy things, or you're brushing your mouth really hard. Like it's gonna hurt. So if you've had one of those, that could also be like an idea of like how you would manage it, if that makes sense.
I think it is a complication because they are immunocompromised, and the oral orifice is already considered a dirty orifice. So if they're immunocompromised, they don't have the adequate white blood count and the immunity to protect themselves from battling infection. So they have to maintain adequate oral hygiene, but not extensively in the sense like Alicia explained. So they don't don't use a gentle brush rather than the regular brush. So you don't overdo it, if that makes sense.
Yeah, I think you said that very well. Okay, yeah, so that's what stomatitis is. Like I said, if you've had a canker sore, that could also be like just an idea of like how to think about it. Um, but okay, so we talked about manifestations, and managing cancer means managing the symptoms, right? Because we want them to be the most comfortable and we want to alleviate the discomfort. So we said potentially problem is bleeding. So this question says list the signs and symptoms of chemotherapy and assess for bleeding at the intravenous site. In other words, what do we do if someone has bleeding? Well, we're going to apply pressure, right? At the site. That's what we're going to do to stop the bleeding. The next question talks about complications of receiving chemotherapy. Well, chemotherapy could cause extravasation. So we need to watch out for things like redness or arrhythmia, warmth, swelling. I think it's called slaw. I think I'm saying it right. Um, and necrosis. So we're looking for things like that. As well as we can give them the antidote if we see these things occur, which is dimethyl sulfoxide. And we want to assess for the effectiveness of the antidote, and hopefully the extravasation, that redness and stuff will start, to go down. And yeah, so like I said, complications of chemotherapy, we're looking for extravasation and as well as giving them the antidote to prevent that. And extravasation could, potentially lead to bleeding. So that's why one of the things, if we see bleeding, we want to apply pressure at the site. So, the next, we already talked about complications of chemo. So I'm not going to really get into that. I think the one thing I forgot to add was the dry and wet I don't know how she says that word, discriminants. But the dry ones are scaly, dry, itchy, and they have like slaw on it, whereas the wet ones are like blisters. So those are also other chemotherapy complications in addition to all the other ones we said, right? Like myelosuppression. So we have to watch out for thrombocytopenia, neutropenia, anemia. They have poor nutrition. They have cachexia or muscle mass loss, right? They're also going to have, we said, stamitis, alopecia, nausea, vomiting, all of those things. And so we need to watch out for all of those things and treat them. Okay. So, since we talked about manifestations, the next question is provide nursing education to a client undergoing chemotherapy. So things like wearing a wig, right? If alopecia takes place, if that's something they like to do, right? No herbal supplements because that can intervene, right? And you always want to be careful with herbal supplements with any medication, right? Avoid spicy foods, right? Especially like when we were talking about like stamitis, that could be very painful. Calcium levels. This is something that Dr. Remy specifically emphasized, that they can have hypercalcemia, so they need to monitor calcium levels and discontinue any calcium supplements that they're taking. We want to prepare the patient for nausea and vomiting. They might tell them that they might have GI complaints, right? And avoid exposure to the sun, right? They're immunocompromised, right? And the sun can also promote, skin cancer and other complications, as well as just be harmful to the skin, and it can cause delayed healing. So none of that would be good for them. So those are just some interventions that Dr. Remy mentioned. Is there anything else that anybody wants to add? Okay. So like I said, these are the different types of education that we can give. The wigs, no herbal supplements, avoid spicy foods, avoid sun exposure, tell them about the GI upset, prepare them for nausea and vomiting, and make sure we watch out for those calcium levels because they can have hypercalcemia. The next question is to provide nursing education for safe administration of neoplastic agents. So I did see a few questions on this on CoursePoint, and most of the answers pertain to wearing surgical gloves or disposable gloves, sometimes they refer to them as well as a protective clothing. And Dr. Remy specifically mentioned, like, not discontinue, to dispose the waste in like a biohazard double bag. So we double bag it and we put them in those biohazard bags to dispose the waste. Is there anything else that anyone wants to add? Okay, so most of the time I see wearing surgical gloves and protective clothing, as well as, like I said, we want to dispose them in those biohazard and those and double bag it. Okay. So the last thing is to list complications for a client receiving radiation therapy. So pretty much it's the same sorts of symptoms that we spoke about, and this has focused on the skin assessment. So we started talking about, like, stomatitis, alopecia, right, the dry and wet, discriminations, right? We're looking at those things. They could also have a metallic taste that can come off after radiation. So those are some things that we want to look for, but it's very similar to what we spoke about with chemotherapy, though there is different types of radiation. So if you're getting external radiation, we need to make sure that they know that they're going to go for 5 days straight, and they don't want to remove the markings for where they're doing the radiation, or which are also called radiation markings. And at home, they should only use mild soap and water to clean themselves, nothing harsh. For internal radiation, I know she mentioned things like thyroid cancer, iodine 131. It could be sealed or unsealed, but the iodine 131 is unsealed. It stays in the body for 48 to 72 hours, right? They can't see anybody for 2 weeks, and they need to flush the toilet 3 times or several times every time they go to the bathroom, right? Precautions, because it's inside the body. We're talking about radiation internally. We're talking about keeping a sign on the door that lets them know, hey, this patient's on radiation precautions. We should keep 6 feet of distance from them and should spend no more than 30 minutes with them. But if we have to do direct care, we should be within 3 feet, right? They should have a private room. They should have Foley catheters and be on bed rest. They should not really have many visitors, and especially no pregnant women, because we don't want to expose radiation to a growing fetus, right? We need to wear surgical gloves and protective clothing when we're handling, chemotherapy agents, dispose of everything properly. She said we need to keep forceps at the bedside to prevent any sort of dislodgement, and we need to have shielding or lead aprons, right, when we are entering the room. Is there anything else anyone wants to add? Okay, but I think this question is just simply going to be the complications of radiation therapy, like skin related. So we talked about wet versus dry, alopecia, stomatitis, things like that, as well as petechiae or ecchymosis, because those are skin changes that could happen because of thrombocytopenia. But these are just other things that happen, with cancer, because everything's a fair game, since she mentioned it in the overview. Okay, now we're on respiratory, which means we only have like 20 questions left, so we're getting there. Getting towards the end. So the next question is to perform a physical assessment on a client experiencing dyspnea. Now, she said for this question, specifically, if they said they can't breathe, they feel like they're gasping for air, our first thing is to ask them about the severity using a scale from 0 to 10. And actually, in the textbook, I found this, it asked a different it had a bunch of different questions that you could help determine the cause of dyspnea. But one of them said, ask them, how severe is the shortness of breath on a scale from 0 to 10? If 0 is not at all breathless and 10 is very breathless, how hard is it to breathe? This is the question that we should be asking a patient who's experiencing dyspnea. And remember, dyspnea means that we're having expirations that are going to be greater than inspiration. So they're going to have air trapping, which means that's going to cause them to have shortness of breath. So our goal is to ask them how severe it is. Okay. Of course, we're going to ask them other things, you know what I mean? Like, when did it occur? All of this stuff. Does anything help? But our main priority is how severe it is, right? Like, they really feel like they can't breathe. We're going to have more immediate interventions than ones that might say, oh, just a little. You know, we have to assess how severe the situation is before we can ask more questions and provide appropriate interventions. Okay. The next question was to identify abnormal breath sounds, which reveals high-pitched sounds and auscultation. Now, I found this chart in the textbook. So, what I found that were high-pitched were fine crackles, not just regular crackles, fine crackles, wheezing, stridor, as well as pleurisy. Those are examples of adventitious, which also means abnormal breath sounds that cause high-pitched sounds on auscultation. Anything anyone else would like to add for this?
I have a question.
Okay.
For the high pitched sounds, like, do you think she might make it like a select all and apply, or would she just give an example, like she was saying, like if it's, let's say, asthma, it's gonna be wheezing, where it's clear that it's just one type of breath sound.
I have no, it could be either. She could ask which of the following are, and which of the following is an example of a high pitched sound, or select all of the following, which ones would be high pitched sounds. I think either would be applicable. That's why I mentioned at least different examples of what high pitched sounds are. I have no idea. She does like select without apply, so I would not be surprised if she puts it.
Alicia, is pleurisy a high-pitched sound, or is that like a condition, pleurisy?
Well, it does cause like fluid buildup, so it could lead to like higher pitched sounds. If I saw it on a select all, I would pick it,
Oh, okay.
sort of thing. Because I remember she kept mentioning pleurisy, and then she also mentioned like pleural fiction, but they're different. But they would cause abnormal like breath sounds.
Yeah, that's a condition.
That's
Pleurisy.
why yeah, but she kept mentioning it in the thing. So I don't know. I feel like she would pick it. I don't know. You guys could tell me. I feel like she would put something like that on there.
Okay.
But like in terms of like adventitious sounds, according to this specific chart, it's fine crackles, wheezing, and stridor. And then she also kept mentioning pleurisy. So, um, I feel like if I saw it, I would pick it unless, like I said, I'm down for anybody sharing what they think. I want to make sure we're all on the same page.
Just make sure vesicular lung sounds are normal lung sounds. So she can throw one of these examples in there and you would pick it because you think it is abnormal, but it's actually normal.
Yeah, that's a good point.
Yeah,
So is bronchi and bronchovesicular. Those are normal.
those are normal.
Yeah. So honestly, the question could just be identifying abnormal breath sounds. So I just pick anything that would look abnormal because
But let's it's a lot simpler. So if we're talking about any complications in the lower lobe of the lungs, she's very heavy on crackles, maybe bronchi, and maybe pleural friction. If it's going to come to the upper airway obstruction or inflammatory response like asthma, then you can't be picking crackles for that. You would have to pick stridor or wheezing. That make sense, Natalia?
Oh, yes, thank you. I just remembered, I think during the review or in class, she was mentioning like different conditions, like,
They
crackles for pneumonia,
there are
pleural effusion for pleural friction rub.
but you have to relate them to what part of the respiratory, if it's upper or lower respiratory. Each of these sounds pertains to a certain region. So the lower you go in the lobes, those are the ones that you're going to hear bubbling, like coarse crackles. Um, if you're going to be in the upper airway and it's like you really just airway obstruction, like the windpipe is obstructed, so you're not going to hear crackles there. You're going to hear something that is like wheezing and stridor. Can't go wrong with that.
Yeah, I agree. I definitely think it depends on the question and it depends on what's going on. Like I said, if it just said to identify high-pitched sounds, these are some of the ones that I found that were related to specifically high pitch. So we know if we're talking about upper, we're talking about like wheezing or stridor. And as you know, Safin said, if we're talking about lower, we're thinking more about like crackles and rails and things like that. Okay. So we went over the sounds. Like I said, it all depends on the question. So we just have to think about what's going on and consider what type of respiratory problem they're experiencing. So the next question is the priority, nursing priority for a client with a mediastomy. I'm terrible at saying things. So we're just gonna go with that, right? So it's basically a hole in the mediastinum, so the patient can have more space in the lungs, so the lungs can expand and they can breathe better, right? So typically after this procedure, they will get a chest tube, and that's what Dr. Remy was putting an emphasis on, that they're gonna have a chest tube after. So we are gonna have to assess for that, right? So, other things that I found was that, right, we're talking about a chest tube, we're talking about a hole that was being made in the chest area. So we need to make sure, right, they don't have respiratory distress and that they have adequate oxygenation, right? We want to look at bleeding, we want to look at pain relief, right? And we also want to make sure that we're carefully assessing what's going on with that chest drainage, because if there's a lot of it, if there's a lot of frank red blood, that means they're actively bleeding. So those are things that we want to look at. But I think if this were a question, the priority would be, right, making sure that they do not have respiratory complications post operatively. Does anybody have anything else they want to add? Okay, so like I said, chest has a big hole, so obviously we want to make sure that they're able to breathe and they have, no airway obstructions and things like that. Okay, so now we have pneumonia. We have a few questions on pneumonia, so I'm gonna kind of tie both of them in together because the question is to manage the care of a client related to pneumonia and also assess and provide nursing management to a client with pneumonia, which I have the same exact things for. So I'm not gonna like read the same questions twice. But pneumonia, by definition, according to our slides, is inflammation of the lung parenchyma, which is basically the alveoli. So there's inflammation of the alveoli, which can be caused by different things like bacteria, fungi, viruses, all sorts of things, right? And patients who are typically at risk for pneumonia are people on vents, elderly patients, immunocompromised patients, and post-operative patients. So that's what we have to think about, right? Okay, who's at risk for pneumonia? Well, we know anybody on a ventilator, anybody who's immunocompromised, anybody who's elderly, anybody's post-operative. So if we're thinking about these things, we see this as a respiratory problem, right? They have inflammation of that alveoli. So we need to have good management, right? So we need to elevate the head of the bed, right? That's going to help decrease airway pressure and promote lung expansion, right? Anywhere like, in that normal semi-Fowler's sort of thing, right? Give pneumococcal vaccine as well as H influenza, right? We don't want them to get any other infection that's only going to make this worse. Antibiotics, especially if it's bacterial, but we need to get first a blood and sputum culture. We need a urine analysis. We need all of these things to determine what kind of pneumonia is this, right? We want to monitor vitals because especially if it's bacterial, we'll expect fevers, we'll also expect tachycardia, and we'll also expect an SpO2 level to decrease, right? We want to look at that BUN and creatinine level, and we want to look at that urine-specific gravities because we're looking for dehydration, right? Because infections and fever can always lead to dehydration. We want to also help with loosening up secretions, right? They're at risk for secretions, right? Because they're going to have, maybe if it's bacterial, lots of productive coughing. So to loosen secretions, we can encourage fluids, we can turn them side to side and promote mobility if that's possible. We want to also prevent aspiration, so we want to keep the head of the bed elevated, right? We can give oxygen to them, especially since that SpO2 is going to be lower, and if it gets a little too low, we want to give them oxygen. We said this is an infection, so we're looking at white blood cell counts. And because, remember, we said fever earlier can cause respiratory alkalosis. So we have to watch out for ABGs. They're at risk for that because of the fever. We talked about sputum and blood cultures. We want to look at an x-ray to see if there's any fluid buildup and what's going on in the lungs, right? Especially they could have a thoracentesis depending on how much fluid is there. We want to assess lung sounds, right? So we want to look for, typically we'll hear diminished breath sounds and crackles because of fluid buildup in the lungs, right? And we said it before, normal is vesicular, bronchial or bronchovesicular. We want to teach them diaphragmatic breathing, right? This is respiratory, so you got to think about all respiratory interventions, right? Chest PTs and census spirometer and diaphragmatic breathing exercises, or pursed lip breathing, which is, she said it's used interchangeably, which help expand the lungs, reduce airway resistance, and promote oxygenation. And last, we want to look at the skin because they're at risk for a hypoxemia, okay? These are all the things. And even if it doesn't, like I said, it could be hard. You don't have to memorize everything, but think, right? Infections. I need to assess the infection. I need to do interventions that would determine the infection, but also help prevent the infection. This is a respiratory problem. So what are my respiratory interventions? Anything that has to do with respiratory interventions for a selector that apply, pick it, right? Elevate head of the bed, give oxygen, right? Chest PT, all of those things, all of them would be acceptable answers because it has to do with a respiratory problem and all of those things. So like I said, I'm not going to go into the management, but just like I said, depending on the type of pneumonia, we could see fevers. We'll definitely see tachycardia and tachypnea because it's a respiratory problem, right? Dyspnea, productive or non-productive cough. Like I said, if it's bacterial, it will be productive. SpO2, because it is pneumonia, is going to be less than 95, and they could also be cool and clammy. Okay. All right. Now we're on 18, which is the management of upper respiratory function. I don't know why this says 2. I can't change it to 1, but it's not missing a question. It's just, I don't know. But we already talked about like the pathophysiology, the clinical manifestations, the nursing management with the client with pneumonia. What I want to identify to you is pleuritic pain, which, because that's what this question says, that they're having pneumonia and pleuritic pain. So pleuritic pain is basically irritation of the parietal pleura, which is going to cause sharp pain on inspiration. It's going to almost feel like a stabbing sensation, okay? So they're experiencing that. So management, we already talked about different ways that we can provide management for pneumonia, right? And they're having pleuritic pain, so we want to help reduce their pain. We also want to give them oxygen, right? Always assess vitals and monitor oxygenation status. We want to assess lung sounds, right? You already said we expect them to be have crackles and diminished breath sounds. She said urine antigen test to test for Legionella, which is, I looked it up. It's basically like a type of infection that you can get with pneumonia. So you want to check for this. We want to give antibiotics, right? We said it could be bacterial based. We want to do blood and sputum cultures. We already said that. And monitor for respiratory failure and ABGs because they're at risk for respiratory alkalosis. with the fever, and it could also progress to respiratory acidosis, right? So once again, respiratory interventions, but specifically, I would know that when I see this question pertaining to pleuritic pain, besides all of the interventions that we said, we need to do a urine antigen test for Legionella. Nursing diagnoses, we're talking about a problem with respirations, right? So we're talking about ineffective oxygenation, right? We said that SpO2 is low, right? They might have ineffective gas exchange, right? Because we're talking about inflammation of the alveoli, right? We're talking about potential ineffective airway clearance if they have a lot of sputum buildup, activity intolerance related to hypoxia, and a risk for fluid volume deficit because of fever and rapid respiratory rate from the respiratory alkalosis. So we see how all of these nursing diagnoses pair with the presenting symptoms. Okay. So the next question is to provide patient education for a client with pharyngitis. So what Professor Remy put an emphasis on was making sure they take the full course of antibiotics, because acute pharyngitis could be caused by, bacteria, especially streptococcal, is a very common cause of acute pharyngitis. So we want them to take the full course of antibiotics. Now, I went into the textbook and found other patient teaching, so I'm not going to get into like all of it, but basically, right, they should cough and sneeze in their upper arm, dispose of tissues properly, right? Since they could have a sore throat, we want to have warm saline gargles and maybe an ice collar around the neck to help relieve a sore throat. We make sure that they do not go back to work until 24 hours after antibiotic activity, because if antibiotics is not in your system for 24 hours or more, you still can spread the infection. You also don't want to share anything like utensils, anything that you put your mouth on, right, or touch yourself with, and make sure that you replace your toothbrush as well. So those are just some different like interventions for pharyngitis because it's an infection. Okay. So the next question is to provide nursing interventions for a client with tube feedings and rationale. So when we're talking about tube feedings, right? We're talking about what are we going to do if someone is on a tube feed? Well, one, we want to elevate the head of the bed to prevent. Why do we want to elevate the head of the bed in either semi-Fowlers or high Fowlers? Why would we do that?
Avoid aspiration.
Exactly. So in that token, if we want to prevent aspirations, we also want to hold feedings when we move them because they're at risk for aspiration. Before we even start feeds, we want to check for placement, which is where we could put 30 cc's of air into a little syringe. And we basically put it into the tube. And we auscultate the stomach to see if we hear a swoosh sound. And if we do, we know that it's in the stomach, and that's good. We could also want to check pH residual before we start feeds. Like, let's just say we stop them, we want to restart them or whatever, right? So she said no more than 70 cc's, because if it's more than that, we want to hold. And if it's less, we could put it back to the patient, and that's because a normal syringe would be like 60 to 70 cc. So if you have more than that, or you're getting that much in a syringe, that's very concerning. That means they're not digesting their food properly, which puts them at risk for aspiration. She also said before we start feeds, we need to auscultate all 4 quadrants, starting with the right lower and going up. So then to the right upper, left lower. Okay, we want to make sure we hear gurgling sounds. If there's no gurgling sounds, we're not going to give it. And tube feeds must always be given with sterile water, not normal saline or anything else, okay? Because we also want to prevent the risk for infections, and sterile water is better and more compatible also with the feedings than other solutions, because the feedings also have sugar. So if we're using different solutions, that could just increase the infections even more. Okay. So we talked about all of those things and what we need to do for interventions when someone has tube feedings. Okay. The next one is providing nursing interventions for a tracheostomy. Remember, this is an artificial airway, right? This is helping them get air. So our priority is airway. So we want to clear the airway with suctioning, right? And we make sure it's always clear from obstructions. We also need to make sure that the cuff is always inflated. It should have 10 cc's of air. And if it has less than that, they're at risk for aspiration pneumonia, right? And if it's higher than that, it could actually cause like tracheal bleeding and ischemia. It could actually cause problems and damage to the trachea. So we need to make sure that the cuff is inflated, to emphasize that the lower, if it's not, does not have the 10 cc, it's less than that, it can cause aspiration pneumonia. But our priority is to maintain a patent airway. So remember, it's an airway, so nursing management, always monitoring. We want to monitor for respiratory complications, especially. We want, as well as ABGs, right? We want to maintain patency through suctioning. We shouldn't suction for more than 15 seconds. And always auscultate before you suction because you want to know what's going on in the lungs, right? We want to keep them semi-foulers, right? Because we want to make sure that they're getting adequate lung expansion so that, the trach can do its thing. We can give pain medications as well as sedatives, right? Because patients sometimes fight the trachs too, which can also affect their respiratory status, right? A means of communication, so such as writing and things like that, and how to teach the family and patients on daily care and how to prevent emergencies. Is there anything anyone else wants to add for this question? Okay. So the next question is to assess and provide nursing interventions for a client complaining of a sore throat. So we know that sore throat, right? They're going to have pain, right? They're going to complain of pain and it's going to be all red. And a lot of us have definitely experienced a sore throat in our life. So we want to prevent giving them hot or spicy foods. We can gargle with warm salt water. Like I said, also ice collars is another thing that they can put on. Um, Acetaminophen or ibuprofen for pain. Always hand washing, especially for the kids, because kids don't wash their hands and that could cause an infection, as well as expectorants like guanfacinin and mucolytics to help remove any sort of mucus buildup that they could be getting. But yeah, we're thinking about sore throat, right? Like we don't want anything too cold or too hot, right? Warm salt gargling is going to really help and things like that. We want to do pain management as well. Okay. So the next thing is to indicate lab values to perform on a client with cancer of the larynx. Focus on nutritional status. So the things that Dr. Remy mentioned was a CBC, a BNP or a basic metabolic panel, which is basically telling us our electrolytes, our ABGs, right? Because this is also a larynx, it's going near airway, it could affect airway, so we want to see ABGs. We want to look at, if we're talking about nutrition, albumin and protein levels, as well as blood sugar levels. And for albumin, I wanted to know a little bit more about it. So albumin, if it's low, it can affect the kidneys and the liver. And if it's high, it could actually mean that the patient's at risk for dehydration. Is there any other sorts of lab values or anything else anyone would want to share for this question? Okay. So this is our last set of questions. So we talked about a sore throat, right? We talked about all these things, and now we're going to list the signs and symptoms of acute pharyngitis, right? So we know this is an upper respiratory complication, not a lower respiratory complication. So for acute pharyngitis, it's, if you think of that picture that we had in the slides, it was like all red, right? And everything was swollen. So they can have a sore throat, and we already know our interventions for sore throat. We talked about warm gargles, pain management, things like that. They're going to have a fiery red, pharyngeal membrane and tonsils. They could have exudate. They're going to have swollen lymph nodes, right? The tonsils could be touching each other. They can have a fever of typically greater than 101 and have difficulty swallowing. Now, this is just from the textbook. It's literally reiterates what Dr. Remy said. It's the same sorts of things. It was just talking about if you have different types of pharyngitis, what other symptoms you may expect, but these are the things we're looking for, right? Sore throat, fever, fiery red tonsils, right? Exudate, difficulty swallowing, right? Swollen lymph nodes, things like that. Is there anything anyone wants to add? Okay. So the next question is to identify signs and symptoms of respiratory distress for a client with laryngeal obstruction. This is upper respiratory, okay? So if we're talking about laryngeal obstruction, something that I got from the textbook is that basically this is really, really bad. This is when we're having edema of the upper airway. So when you hear laryngeal obstruction, think of airway obstruction, which means this patient is having respiratory distress. So what are some signs and symptoms that would let you know as a nurse that this patient is having a really, really hard time breathing?
Gasp for air.
Exactly. What else?
Strider.
Mm-hmm.
Using the accessory muscles of the neck, the shoulder.
Yep. What
Breathe.
else?
Becoming confused and loss of conscious.
They could definitely be confused, right? So everything,
Nasal flaring because
yeah,
they
I was waiting for that one. Yeah, those are all really, really good, right? So gasping for air. So when you think of laryngeal obstruction, we're thinking airway obstruction, we're thinking looking at a patient who looks like they're really, really struggling to breathe. So we'll see nasal flaring, right, while gasping for air, right? They'll have dyspnea, tachypnea, or even an increased effort in breathing. All of those words can be used interchangeably. Use of accessory muscles, right? As someone said, the neck and the abdomen, you could see this in, right? We have to be very careful, right? Because these could all lead to respiratory collapse. Lung sounds are going to be diminished. We could potentially hear wheezing. That's something that Dr. Remy mentioned, right? As well as potentially stridor, right? But stridor is typically something you see more in children. So wheezing would be more characteristic for this. We also want to monitor ABGs. Why? Because if they're having problems breathing, they're having respiratory compromise, they're struggling to breathe, right? They're going to have respiratory acidosis, going to have too much carbon dioxide. They can't get rid of it because they can't really breathe, right? So they're hypoventilating. Even though they're struggling for air and they might look like they're breathing, quicker, they're also not able to breathe at all, and they're not able to expel CO2 as well. So that's why they'll go into respiratory acidosis, okay? And they'll have an SpO2 of less than 95%. Is there anything else that anybody wants to add? Okay. So you basically hit everything on the head. Remember, when you hear laryngeal obstruction, think, what will my patient look like if they're really struggling to breathe? Okay. I know that's like a terrible thing to think about, but it might help you at least think about the symptoms much easier. So, the next question is to provide teaching to a client with periodic sneezing, runny nose, itchy eyes. I think of allergies when I see this, or irritants. Something's bothering them. So, what are we going to tell them? Hey, you should avoid irritants and powder and scented products and perfumes because that's going to bother you more, right? Smoke or smoking would also irritate you. You should stay away from that. Nasal sprays, if they have one, they should perform hand hygiene before, they should shake it before, and they should also clean before and after use. Right, we want to educate them on allergies and triggers and as well as on antihistamines, right? So they can help reduce that inflammation or that inflammatory response that they're getting as a result of the irritant. Is there anything else anyone wants to add? Okay. So the next question is to define pneumoconiosis. I have no idea how to say that. But it's an occupational lung disease, right? And we want to provide nursing management to a client with respiratory exposure to an occupational toxin. So we know if we see this word, we're thinking about, okay, someone's being exposed to this in a work-like environment, right? They're being exposed to like asbestos, and all these inorganic minerals that they should not be breathing. But the problem is once they breathe it in, there's nothing really you could do once they start getting damage from it, right? So nursing management, our first priority. What do you think that will be as a nurse when we're going into an occupational setting and we know this could be a risk? Well, what do we want to look at first? Well, we want to look at how long they've been exposed to these things, right? Length of time exposed to the onset of symptoms and how long they've been exposed to the agent. So how long ago were they exposed to such and such thing, right? And how long have these symptoms have been presenting? And next thing that we want to see or determine is do they have the appropriate protective equipment that they need in this environment, to prevent even further complications, right? Yeah, we want to make sure they have masks and things like that and protective gear. So that's our main thing. Our priority is going to be assessments, right? We want to assess now that we've known they've been exposed to this in this work environment, how long they've been exposed to it and how long the symptoms have shown, what sorts of protective equipment they need to prevent further damage and things like that, okay? Is there anything anyone else would like to add for this question? Okay. So, the next thing is to provide nursing care to a client on a mechanical ventilator. So, remember, we're talking about management. Like I said, you can put your pneumonia, most of the, management in here too, because it's like all respiratory complications have similar management, except for this patient, right? They're not going to really be mobile, right? We're not going to be walking them around because they're on a ventilator. So, you can, ignore that one. But what can we do, right? ABGs, auscultating breath sounds, especially every hour after they're first intubated, that becomes a priority. We want to look for things like diminished breath sounds and things like that. It also tells us if the lungs need to be drained because you always need to auscultate before you start suctioning, right? As well as hyperventilate before you suction. So we can suction them. We want to auscultate lung sounds. We want to monitor ABGs. We want to have vitals. We want to look at gag and cough reflex because if they don't have those, even though they're in a ventilator, if they don't have that, that's also a indicator of neurological issues as well as potential respiratory aspiration if, they're getting feedings and just because they don't have a cough or a gag reflex, okay? We want to give them oral care, or also oral care through a Yankauer, which is basically just another tool that you could use to give oral care. It's like a suctioner, like a container, but it's not. It's not used as the same way as you would as like a regular suction. So like don't get them confused, but a Yankauer can be used for oral care, but it's similar to a suction because it has like a little suction mechanism to like clean things up. And yeah, so those are things that we're looking for, right? I'm not gonna get into all these things here, but I am going to go to this part, right? So when we're talking about managing a patient who's receiving mechanical ventilation, these are the things that we need to think about, right? Maintenance for a patent airway, that's our priority. Airway patency is our priority. We need to have interventions that relate to that, such as suctioning, right? Optimal gas exchange. We need to assess the lung sounds. We need to look at these ABGs. We need to know what's going on with gas exchange, right? We want to we want to make sure that there's no trauma there and there's no infection. Okay, we need to look for signs and symptoms of that, as well as continually assessing it, right? We want to make sure they have optimal mobility the best that they can, right? In terms of making sure we move them and stuff so that they also don't get buildup of secretions and things, right? Adjustments to nonverbal. Oh, I almost moved everything. Adjustment to nonverbal methods of communication, right? Because they're not going to be able to speak, so they should be able to write and things like that. And they need successful coping measures. We want to make sure that they're able to cope with these new changes. So like I said, there's a bunch of different things that we could do to promote airway, to promote gas exchange, right? Even another way to promote airway is that Dr. Remy mentioned is this, which is the bronchodilators and mucolytics that can help make sure that the airway is clear, right? Make sure we take infection and injury measures. Something else that I'd also like to point out is hand hygiene is essential when caring for patients on a mechanical ventilator, right? We want to make sure that also with the mechanical ventilator that they have a good cuff pressure. This also relates to here, right? We want to do oral care and make sure the head of the bed is elevated, not to 90 degrees because it could pull on the tube, on the wires and stuff, but we want to make sure they're at least semi-foulers. That's what we want them to be, okay? And things like that. Okay. Next question is to provide assessment, and indicate findings that would make the nurse know this patient is eligible to be discontinued from the ventilator. So, eligibility. Think about it this way. What would look good? One, normal ABGs would look very good before, because remember we said they're at risk for respiratory acidosis, right? What else? Stable vital signs would be very good, right? What else? A gag and cough reflex, because if they don't have those, they cannot get off a ventilator because they will choke and die on something. So no. Make sure that the patient is able to breathe effortlessly. They're able to breathe on their own, as well as making sure they're alert and oriented. They're not confused, because that could also put them at risk for respiratory compromise, choking, and all of these other problems. This would tell us that they are eligible to be discontinued. Think of, even if you can't remember all this, think of good things. If I'm looking for a selected that apply, I'm looking for good indicators, something that's positive of those results. If it said unstable vital signs, no, right? If it said SpO2 of 80, no. If it said they have no gag reflex or a decrease, no. Like those are things would be bad. If they're normal, that's what we want to see. Okay. The next thing is to identify nursing education for a client using post-oral drainage. So I heard Dr. Remy say clap and tap. If anybody wants to explain what that is, I searched it up and they just said that means like it's a type of percussion, as well as modified Trendelenburg, and basically want to put them in a prone position. Does anybody have anything else to add? I do have a few more things I will add, but I just want to know if there's anything else specifically that she said.
Didn't she say not to put the patient prone position? Didn't she mention something like that today?
I think
For
she
her?
mentioned that for mechanical vent. I thought that it was somewhere. I think it was some respiratory problem that said prone, but I could have sworn. Did
I
anybody
think it
else
is for this one.
for
Because if they have
post-oral?
fluid in the lungs, like you want to be prone so that you can try to promote the drainage, like so that all the mucus and like secretions come out. And it's, I think, a little easier if you're like prone. Just not in a position where like your face is smushed in on the bed, you know?
Yeah. There was something I remember that the teacher did say something with prone, no, but I don't think it relates to this. I remember for this specific question, she said for post-oral drainage, prone, lower the head of the bed, modified Trendelenburg, and clap and tap. Something else that I saw for post-oral drainage is that for auscultation, it needs to be done before to determine the effectiveness and if there's actually a need for drainage. And it also let us know when we auscultate after how well were we able to drain those lungs, right? Also, I saw the textbook said that when when the head is down and you're in that let's say prone position, you're more effectively clearing those lower and middle lobes. Whereas if they're sitting upright, it actually helps with clearing the upper lobe. So there's different positions, but typically for this, as she said, prone, lower the head of the bed, clap and tap. And remember, the goal of post-oral drainage is to have gravity assist in forcing the removal of those secretions, right? So when they're in these positions, these prone positions, it's going to help facilitate those secretions to come out. Also, other things that I wanted to point out is that post-oral drainage should always be performed before meals to prevent aspiration as well as before bedtime, right? That would make sense. Do it before bed so you have a clear respiratory function before you sleep. Oh, it says to tell the patients to start with the lower lobes first. That's why we want to start with those prone positions. And then modified Trendelenburg. They should be in every position for 10 to 15 minutes, okay? And then when they're done, they should make sure they have to cough, right? They need to cough when they're changing positions because we want to make sure we get those secretions out. And as well as using pursed lip breathing while they're in those positions to help facilitate removal of secretions. Those are just some other things that, like I said, I saw in the textbook, but what Dr. Remy put an emphasis on is clap and tap, modified Trendelenburg, prone position. Remember, we're helping in those lower positions, like in prone, helping get rid of secretions in the lower lobes and the middle lobe of the lungs. Okay, so the next question is to identify the highest incidence of pneumonia in a client with AIDS. So, when a client who has AIDS, HIV, or transplant, they're at risk for pneumoniacitis. I can't say it, but or pneumonia cystic or PCP, also called opportunistic pneumonia. I want you just to have different, ways to say this, but this is what we'll typically see in a patient who is severely immunocompromised. They're at risk for pneumonocytitis, which is also, like I said, PCP, which is a serious infection caused by this fungus called pneumoniacitis. I don't know how to say that other one, I don't know how to say that, but it's caused by that fungus, and it's typically seen in patients who have, like I said, who are HIV, AIDS, or even transplant patients. I think it's just going to be which type of pneumonia would you expect to see in a patient, in an AIDS or HIV patient, and I think this is the type of question that's going to be. We could also give Bactrim or pentamidine and amphotericin B. I'm probably butchering these medication names, but those are the types of medications right here that we can give to a patient with this. Okay. Okay. The next question is to provide nursing care to a client with post-thoracic surgery with a chest tube in place. Indicate the rationale of the chest tube. Now, there's two things that Dr. Remy said was one, to remove air from the lungs. That's why we do it. The second thing is that we know the chest tube's not working when there's continuous or constant bubbling or continuous or constant fluctuations in the water seal chamber. If there's regular fluctuations, that's good. That means it's working. If there's continuous or constant fluctuations, that's bad. That means there's a leak. If there's no fluctuations in the water seal, that means that they have a kink or the tube is clogged. She also said for when someone who has a chest tube post-thoracic surgery, we need to assess the amount of drainage, right? We want to look at how much drainage there's there, the color, and the odor. And we need to apply occlusive petroleum gauze dressing onto the chest tube. But the question just simply says to indicate the rationale, and she said to remove air, but these are the other things that I have as well that she emphasized. Is there anything else to add?
I have a question.
Hmm.
What does corpius mean? Is that another word for moderate, or is that supposed to be a different category?
Copious means like a lot of secretions. Moderate's different. I hope that makes sense. So moderate is not as severe as copious. Copious means a lot. Okay. Oh, I also just want to mention, I don't know if I mentioned this before, but she said, oh wait, it's coming in the next question. I'll mention it in the next question. Never mind. Okay. So the next question is to identify signs and symptoms of subcutaneous emphysema and indicate the highest nursing intervention if this condition threatens the airway. So, basically, the textbook says the definition of subcutaneous emphysema is not really a serious complication, but if air sorts leaking or basically there's some sort of problem with absorption of air it can lead to the need for a tracheostomy. So she said if the highest level of intervention for someone who has subcutaneous emphysema and there's a problem with the airway, they're going to get a trach. They're going to get a tracheostomy. Just know it like that. Okay. And basically, when they have subcutaneous emphysema, what's happening is basically the tissues, when you like touch them, like around the face and throat, it's going to be like crackling sounds because you have all this air buildup leaking into these spaces and it could obstruct the airway, and that's why they'll need a trach. Okay. So we already talked about identifying and managing care for a patient who has a tracheostomy, right? Because identifying nursing care, we talk about the importance of maintaining airway patency, making sure that we suction them, making sure that we keep them in semi-Fowlers, and making sure we provide a patent airway. So nursing diagnoses related to a tracheostomy, right? Because remember, this is artificial airway. Problems could be ineffective airway clearance, right? Impaired gas exchange. They are at risk for infection and at risk for aspiration because they have an opening. They have an artificial airway in their trachea, as well as activity intolerance due to hypoxia. So even if I saw a question, it was like, what sorts of nursing diagnoses? The one to prioritize. I think this is just going to be a prioritization question, and it would be like a one-answer question. But it says use the ADPI process to prioritize nursing diagnosis. It's obviously going to be ineffective airway clearance. That's going to be our most important priority, superseding all of these other ones. But like I said, other ones include impaired gas exchange, activity intolerance, hypoxia, risk for aspiration, and risk for infection. Okay. Now, I think this question kind of got molded into one of the other questions, and that's why it's separated. And it says, define the causative factors of collapse of the alveoli and perform a physical assessment for the results. So for Dr. Remy, she said, well, why does a patient have collapse of the alveoli? She said it could be due to trauma, right? It could also be due to increased secretions, also called mucopurulent, also called consolidations. Those are all different terms to basically say increased secretions. So what can cause collapse of the alveoli? Also called atelectasis. We said increased secretions or lung consolidation. I don't even know why that word came out like that. We can have, if it's in a post-operative setting, that can also cause collapse of the lungs, such as heart procedures, thoracic procedures, anything like that, right? Like the mediastinum, right? Let's just say they have a problem with breathing, they have an airway obstruction, they're in the supine positioning, especially post-operative a lot. No cough reflex can cause collapse of the alveoli. Remember, I said you need to cough, you need to get rid of secretions. If not, it's going to build up and it can collapse the alveoli, impair that gas exchange, and as well as pleural effusion. All of that stuff, right? And pneumonia thorax, hemothorax, those can be caused by trauma, right? Pneumonia thorax is air in the pleural space, and hemothorax is blood in the pleural space. So those are things that can cause collapse of the alveoli. Think about anything that can hurt your chest or anything that causes secretions, all of that can cause collapse of the alveoli, as well as problems with breathing. So what are manifestations? Problem with breathing, respiratory. So dyspnea, right? Shortness of breath. Sputum production, because we said what can cause collapse of the alveoli, increased secretions as well as trauma, right? If they're having problems breathing, they're going to have tachypnea, tachycardia, they could have pleural pain, right? They could have cyanosis and even hypoxemia if it gets that bad. So nursing actions to prevent atelectasis include frequent turning and early immobilizations to help promote and loosen those secretions, expand the lungs and manage secretions through coughing, suctioning, and chest PD, and voluntary deep breathing maneuvers and using the incentive spirometer. Any questions?